all of you to this live program at Orthopedic Principles. Today, our guest of honor is Professor Shital Parikh from Cincinnati, Ohio. Professor Parikh is associated with the Cincinnati Children's Hospital Orthopedic Surgery Department as professor and co-director of the Orthopedic Sports Center. He specializes in pediatric sports medicine with clinical and research interests focused on patellar instability, pediatric ACL injuries, arthroscopic treatment of joint instability, and pediatric trauma. After completion of his orthopedic residency from India, he completed fellowships in joint reconstruction at the Hospital for Joint Diseases, New York, pediatric orthopedics at the Cincinnati Children's, trauma fellowship at Sunnybrook, Toronto, and sports medicine fellowship in Cincinnati with Professor Frank Noyes. He has published several articles in peer-reviewed journals and has been the editor of 2 books, Pediatric ACL and Patellar Instability. If you've noticed, Professor Parikh has delivered a couple of lectures on our channel and it's already reached a huge audience. And today is my great honor to bring back Professor Shital Parikh for this wonderful live program. Over to Shital.
Thank you, Hitesh. So the topic is bones that trick you, which are mainly fracture mimickers and missed fractures or hidden fractures in children, what is common, and what can we do to improve our ability to diagnose these injuries correctly and to treat our patients. So first, I'd like to thank Professor Hitesh for the invitation. I have enjoyed the lectures, communication, and interaction in the past. And then I'll start with the lecture on it's focused mainly on X-rays, but we'll touch base where some advanced imaging is required and some tips on how not to miss important fractures in children. So we have come a long way as far as X-rays are concerned. This is the first human X-ray that was Röntgen's wife's X-ray, which was an accidental exposure. And that is when he found out the utility of the X-rays in diagnosing bone conditions, for which he won the first Nobel Prize. Since then, there have been atlases that have been published. This is Keats and Anderson Atlas of the Normal Variants that may stimulate disease. And then my mentor, Dr. Crawford, and Alan Oistrich, who was a radiologist at Children's, he passed away a couple of years ago. They put together this atlas, which is worth reading, or at least worth having it to refer to if needed. So if you get a chance, because this is an old atlas, you might have to search for it. But if you can get a copy, it is worth keeping it for those who are practicing pediatric trauma. Let's see what is irregular ossification, which is normal, but irregular, that means it may simulate conditions. So if you look at the normal ossification of the trochlea, which is here, you can see it's pretty irregular compared to the ossification of other bones around the elbow. One of the reasons elbow joint is really tricky and difficult for those who are not used to treating elbow is the number of ossification centers around the elbow. So one has to be familiar with the ossification pattern, how they appear, how they fuse, in order to differentiate what is normal from what is abnormal. And if you look at the lateral view, and if you're not used to seeing it, you may think that there is a loose piece or a foreign body or some bone chips in the joint, but this is just an ossification variant. Similarly, on the olecranon side, it doesn't just ossify from one apophysis. At times, you will see 2 different centers or sometimes 3. So that's multipartite olecranon apophysis. Now, just imagine you have one of these X-rays in a setting of an elbow injury, and then you have to differentiate what is normal and what is an ossification, normal ossification pattern. This is just from last week. I had this patient who came in because had a fall on the elbow and had significant pain, and this was the X-ray, and the resident said that this is a multipartite apophysis. So one good thing is that if the other side is normal, you can get a contralateral X-ray, and that's what we did. And if you look at the contralateral X-ray, one is that they're very similar. So projection-wise, it's not because of the abnormal view. Both the views are similar, but you can see an extra fracture line in the apophysis on the involved side, and this was a fracture. So if there is doubt, you can get contralateral X-ray, and if there is a fracture, you have to treat it accordingly. So I would recommend that when there is a doubt, especially if there is a uninvolved contralateral side, get a contralateral X-ray, and it will be easier for you to differentiate between what is a normal ossification versus fracture. Now, on the lateral side, is this a fracture or is this a lateral epicondyle? The reason this is confusing because lateral epicondyle appears for a very short time during the development of the elbow. So this is a normal ossification center, but you're not used to seeing it because it's very transient. It just appears for a few months and then it fuses with the main ossification center. So you're not used to seeing this as a separate apophysis or separate center, so it may mimic a fracture. You can get irregular ossification in other areas besides the elbow. For example, the humeral head, you can get irregular humeral head, and then one may wonder whether this is just an ossification pattern or whether in the setting of trauma, is this fracture? In the setting of pain, is this infection? So there can be some confusion. When it comes to the knee joint, you can see this in the weight-bearing areas of the femoral condyle. You can see this small irregular ossification areas. Now, the thing that one has to differentiate is whether this is osteochondritis dissecans, which is pathologic, which doesn't have a good natural history, almost always needs treatment, versus irregular ossification, which needs nothing except observation and maybe a repeat X-ray if there is any symptom related to the knee joint. So how do you differentiate whether this is irregular ossification versus OCD? One is the age. So in kids who are less than 8 years of age, it's almost always irregular ossification, and the kids who are more than 12, it's almost always an OCD. And in between 8 to 12 years age range is the gray area where one has to then rely on your clinical acumen as well as, if needed, higher imaging. There have been studies. This is one study where they looked at what are the patterns of irregular ossification. And you can see that on an MRI, if there is no cartilage involvement, if there is no fluid underneath the area that is irregular, then most of the time this is irregular ossification. And you just need to follow these patients, and you would see that it would just fill in on its own. This is an example of a patella on the left side. It's a normal variant of patellar ossification. On the right side is an X-ray of osteomyelitis. You can see how they can both mimic each other. And in this case, obviously, your clinical presentation would be really helpful. Now, there are variants. That means the epiphysis may appear as if there is a fracture. So let's look at the variants of the epiphysis. For example, this is a cleft epiphysis in the ulna. And this is a normal cleft, and one can be confused that this is a fracture in a trauma setting. Similarly, this is a radial head cleft epiphysis. And you can see that if there is an associated injury, how it can be confused with a fracture. You can also see a small spur in the proximal humerus or the distal radius, which is normal. And then there are variations where normally your epiphysis in the phalanges are distal. And if there is a proximal epiphysis, it may be confusing or mistaken for a fracture in an acute setting. So you can have double epiphysis, both on the proximal and the distal end. You can have a pseudo epiphysis where it's trying to make an epiphysis, and sometimes it can be a notched epiphysis. For example, you can see there is a notch epiphysis on the left side as well as on the other X-rays on the right. And then the shape of the epiphysis may also be confusing. This is all normal, but you can see that because the physis is a little bit undulating, how it gives an appearance of a fracture. And sometimes the epiphysis can be wedged, especially in patients who have some other congenital dysplasias, like, say, for example, fibular hemimelia. you can have a wedged epiphysis, and when it's extremely wedged, you can get a cleft, and that would be confusing to someone, may think that it's a fracture. So you just need to be familiar with how the epiphysis would look on an AP and a lateral X-ray. You have these prominences, the Poland's hump in the ankle, you would see it on the medial side, and then just around the Lister's tubercle, you have the radius hump on the distal radius, which is normal. And then the projection of the undulating or a tent-shaped physis, for example, in the proximal humerus, can give you a false impression that there is a fracture. The black arrows are pointing at the normal epiphyseal line, but based on the rotation of your arm, you may see two lines. One is the anterior, one is posterior, and both are part of the epiphysis, and these are not fractures. But I've seen young residents mistakenly diagnose a fracture when it's just an epiphysis. You can see how the change, how the epiphysis shape or the physeal shape would change with rotation from external to internal rotation. You can see it's more tent-shaped on external rotation, where it becomes a little bit smoother contoured. And on the neutral view, which is in the center, you can see the two lines, which are the lines representing the medial and the lateral lines here. But when you turn it, you can see both. One is the medial, one is the lateral here. So that can be confusing. When it comes to the apophysis of the fifth metatarsal, you have to remember that it's an apophysis, it's longitudinal in its direction and orientation. If you see a transverse line, then that's a fracture. So for example, you see here that this is not an apophysis. The black arrow is pointing towards a fracture because the fracture runs transversely compared to the apophysis, which runs longitudinally. So the orientation can help you to decide whether it's a fracture or not. Now, there are a lot of ossification centers or accessory ossicles around the bones, and you can see most of them are along the distal extremities. That means ankle and lower, ankle and foot, as well as the wrist and the hand. And you have to be familiar, you don't need to remember the names, but just the common ones you need to be familiar. They can appear as if it's a avulsion. The medial malleolus has an ossification center or an ossicle at times, and if you have an injury, it could be a fracture through the ossicle, so it's not always an ossification center. There can be a fracture through it as well, but one has to remember the normal ossicles that are present around the medial and the lateral malleolus. Same way, os peroneum is at the base of the fifth metatarsal, as you can see in the X-ray on the right. It can be mistaken for an avulsion injury in an acute setting. Patella has ossicles. Frequently, we are seeing patients who are very active. They have a diagnosis of jumper's knee or Sinding-Larsen-Johansson disease, and those have these extra ossification centers at the lower pole of the patella, which can confuse someone. If they have an acute injury, it can be acute and chronic, or it could be an appearance of an ossicle, but there could be an injury between the main bone and the ossicle, so it needs to be treated. But don't try to fix any of these ossicles because these are normal and they would not heal. One has to remember the bipartite patella, which gives an appearance of a fracture on the merchant view. But when you look at the AP view, it's almost always in the supralateral quadrant, very frequently bilateral. And this does not need treatment most of the time. Now, as I said, if you had a fall directly onto the knee or over a period of time because of overuse, you do have symptoms, then bipartite patella may need to be treated, and there are various ways to treat it. Similarly, you can get a bipartite navicular, like you can see here. If in doubt, you can get an X-ray of the other side, like this one here, and that's bipartite or the navicular in two parts. Again, the idea is, not to treat these surgically to try and fuse them. The results are not that great. Now you can see some variations in growth, which can be seen both in adults and in children. One of them is the supracondylar spur, and that spur is almost always pointing downwards towards the elbow joint, and that is how you can differentiate it from an osteochondroma, which always points away from the joint. It was described by John Struthers in 1854, present in 1% population. There is a ligament that can be attached to the spur. It's called the Struthers ligament. And that you can see here. Now, sometimes the nerve, the median nerve, can be traveling underneath this ligament, can be a site of compression, but otherwise the spur is benign and does not need treatment. The posteromedial aspect of the distal femur can sometimes have some irregularity, and that can be confusing. It is at the insertion of the adductor in the gastroc tendons, and that irregularity has been studied and has been misdiagnosed with malignancy at times, and unnecessary MRI and unnecessary imaging studies, because if you're not familiar with the irregularity in the posteromedial aspect of the distal femur, it can be confusing. The dorsal defect of the patella is again a normal variation in the development of the patella. It's seen in 1% of the population. It's benign, it can be neglected. And again, just like bipartite, the variations are usually seen in the supralateral quadrant. On the AP view, this is how it may appear. There can be irregularities at the insertion site of deltoid muscle. You can see some irregularity on the proximal aspect of the humerus. And you can see irregularity, especially in younger children. You can see more of these irregularities where the interosseous membrane attaches around the forearm bones. Nutrient channels can be sometimes confusing with fractures, because in kids, some of the fractures are very small hairline, green stick kind of fractures. And so the nutrient channels can be misdiagnosed with fracture. Here's an example of a toddler's fracture, which is a common fracture in kids, but you can see how this fracture line can be confused with the x-rays on the left side. Now, you can see some lucency in certain projections, and you have to differentiate whether that's normal lucency or is pathologic. On the right side, you can see the lucency of the intercondylar notch, which is normal. On the left side, you can see this is a light blue appearance of posterior dislocation. Otherwise, you would not see so much of lucency unless the radial head is, the humeral head is dislocated and internally rotated. Also remember that the real deformity is always more than combined deformity on the two views. So here you can see a CT scan on the AP and the lateral. It doesn't look like there is significant displacement, but when you look at the oblique X-ray, you can see the amount of displacement at the fracture site. When you're diagnosing acute setting injuries, they can mimic or infection or tumors can present as fractures or trauma. So here is an example of a 10-year-old girl who was admitted to the floor because of an ankle injury and her not feeling well. Initially, the ankle injury was ignored because there wasn't anything significantly seen on the X-ray. This is my partner Junichi Tamai's case. After 7 days, the orthopedic service was consulted for cellulitis or increasing swelling around the ankle. Multiple debridements were performed, and there was significant osteomyelitis. It was staph infection, debridement of the calcaneus, and this is 4 years post-op where everything is fused. But it started with a trivial injury to the ankle, and so an infection can mimic or can have a history of trivial trauma, so one has to be suspicious, especially if the patient is having fever, more swelling, redness, not feeling good, then infection needs to be high on the radar. This is one of my patients, 6-year-old female who came in the clinic because of an injury, and then you can see a little bit of irregularity in the metaphysis of the fibula. The report said non-displaced metaphyseal fracture. So we put the patient in the cast, and the patient came back 3 weeks later. And now at 3 weeks later, the cast was removed. Now, 5 weeks later, you can see the amount of swelling that the patient has. So obviously we got an MRI, and you can see that it's not just an abscess, but there is a lot of involvement of the bone as well as the tissue, and this was an osteosarcoma. Proper workup was then done, treated by my colleague who is a tumor surgeon, and the patient ended up with an amputation. The reason I feel bad about this case is because I had initially seen the patient and diagnosed it with a fracture based on the history that was given that there was a trauma, and then the patient ended up with an amputation. So one has to be suspicious when the history is questionable and the exam is not, confirming about a fracture. One has to suspect infection as well as tumor. The other thing is very small kids, usually infants less than 1, but up to 3 years of age, you need to differentiate it from non-accidental trauma, which is intentional child abuse, because if you let the patient go back to the family or go back to the same setting, there is a high chance that the patient is going to have repeated trauma and sometimes even death. So it is really important that one would diagnose child abuse or non-accidental trauma. There are types of fractures like corner fractures, and you can see here the distal femur has what is called a bucket handle fracture, and then you can also see a corner fracture of the metaphysis of the distal femur and proximal tibia. And then these are on the right side is the fractures with high specificity. If you have one of these, then you do need to make sure that you refer them to child life or child protection services or whatever services you have available for protecting the patient. So an infant with a rib fracture, a scapular fracture, a distal clavicle fracture, or multiple fractures in different stages of healing, and complex skull fractures are all very specific for non-accidental trauma. However, one has to differentiate real trauma from non-accidental trauma, and most of the times you would see mid-clavicular fractures from childbirth. If they had a difficult labor, you can see a clavicular fracture. And then single long bone fractures because of accidental injuries. Maybe the parent may have dropped the kid or may have had a fall. We have had multiple history, like patient carrying the kid and had a fall themselves, causing the patient to fall and then having a fracture. And so one has to be vigilant about diagnosing it, but not overdiagnose either. There can be other reasons of having fractures in infants, including metabolic bone disorders or collagen disorders. And there have been, malpractice, or I would say lawsuits about patients who had collagen disorders but were diagnosed with non-accidental trauma and then went on to have other conditions. So this is a report. You can see a case series of 72 infants whose parents were accused of child abuse and neglect, but they had other reasons to have the fracture, like vitamin D deficiency or hypermobility disorder. So it goes both ways. You don't want to underdiagnose and you don't want to overdiagnose. So sometimes if you have suspicions, it's better just to refer the patient to a child life specialist who can then take proper history, check the family setting, check the surrounding, and confirm that the patient has a safe place to go back to. Now, these were all not fractures. They were fractures which were they were mimickers of fractures. That means ossification patterns, infection, tumors that came in because they had a history of trauma, and at one point we thought that they had a fracture. Now let's look at the ones which are truly fractured and not diagnosed, which are the other side of the spectrum, missed fractures in children. If you look at this prospective cohort study, it's a good study, done. I think it was done in Canada. They prospectively enrolled 2,302 children, and of which 247 or 10.7%, there were errors in interpretation of the x-rays by the ED physician, and there was discordance between the read from an ED physician versus a radiologist. And what happened is like half of the patient had to be called back to the ED for further treatment, or in the orthopedic clinic. And then it was also the other way around, where the ED physician thought it was a fracture, it wasn't, and they ended up with unnecessary clinical visits to the orthopedic center. So both ways, there were errors, at least 1 in 10 patients. There was higher odds of discordance if the physician's pretest fracture probability was less than 20%. That means the physician's clinical exam did not point to a fracture, the patient did not have much pain, or the injury was around the joint compared to injury along the long bones. So if you have a patient who doesn't have much pain, injuries around the joint, and physician's clinical exam doesn't point towards a fracture, then there is high chance there can be a discordance. If you look at where the missed fractures were, and let's just focus on the more severe ones, because those probably do require surgery, and the displaced medial epicondylar fractures are important. Bowing of the distal radius in the ulna, if you don't treat it, you can lose forearm motion. And then Salter Harris or intraarticular fractures of the distal tibia. So we can look at a few examples. If you just look at the areas where the fractures are frequently missed, you can see that the ones that are missed mainly in the ankle and the foot, that means the distal extremity, and then wrist and hand, which is the upper distal extremity. So both at the distal end of the extremities where the fractures are frequently missed. Here is a kid, I've just seen this kid last month, and the patient was stumbling, landed wrong, and patient had been to the ED and then referred to the orthopedic clinic for this diagnosis, aversion fracture of the dorsal proximal talus. They put an arrow there to make it easy for us to diagnose. But when I saw the patient had swelling, pain, inability to bear weight, everything on the medial side. So it doesn't look bad on the x-rays. I was suspicious of a fracture on the medial side. Our fellow was not. So we did get a CT scan, and that showed this medial malleolus fracture. Now, the fracture displacement measured about 1 millimeter, so this patient was treated conservative, but I would not have been surprised if it was 2 millimeters and required surgery. So a CT scan does help to diagnose, especially around the distal femur and the distal tibia. Intra-articular injuries have very low threshold of getting CT scan for these kids. We looked about 10 years ago at the ankle injuries. We looked at x-rays and we looked at the CT scan. And then we had raters who would rate how they would treat a patient based on x-ray, and then look at the CT scan and then say how would they treat the patient based on a CT scan. And what we found at 46% of the time, the fracture pattern changed. So what a rater saw on the x-ray, it was different than actually the fracture pattern on a CT scan. The fracture displacement changed from less than 2 millimeter on an x-ray to more than 2 millimeter on a CT scan 39% of the time. That's a very high rate of change in your measurement. And then the treatment changed in 1/4 of the patient, went from non-operative to operative treatment. So one can see how the CT scan can influence not just the diagnosis, but also the treatment of these fractures in children. So we have very low threshold for triplane, Tilo fractures, Salter Harris 3 and 4 fractures of the distal femur. Anything intra-articular, get a CT scan, you'll be able to see the fracture much better. That also brings to one other pattern of fractures that we see in this tibia fractures is a fracture of the shaft of the tibia with an intra-articular fracture of the ankle. As you can see here, that goes frequently missed because you focus on the more obvious fracture. And here you can see a CT scan was done, which shows the intra-articular fracture. Here, the fracture treatment did not change. It was still treated conservative. This was diagnosed at around a month after the injury, and did not lead to any issues with the patient's ultimate result. But I have treated the shaft and the triplane or the intra-articular fracture both at the same time, as well as late presenting triplane with a shaft. It's called the complex triplane fracture when both fractures are present. There have been reports about that as well. There can be other injuries that can be missed. Here is a patient who came in because of pain over the medial aspect of the knee, not being able to do his sports because of pain. Injury was 2 years ago. and you can see there is a little bit of edema on the original x-ray. So very smaller version. I probably would have treated him conservative back then anyways. But sorry, but then after a year, he was still symptomatic. So another surgeon took him to the OR to check the medial meniscus. The medial meniscus was okay. They did a plica excision and said that everything is normal, and the patient was still symptomatic. And that is when I had seen this patient. So has been having pain for a long time, already had a surgery done. And I got a CT scan, and the report was unremarkable exam by CT. This is what the radiologist's report was. But when I look at the CT scan at 1 year, I can still see that fragment. So I talked to the patient, I took him to the OR, and this is an avulsion of the deep MCL. It's not a common injury, but when you can see an avulsion and when the patient is point tender there and hasn't healed for a year, what are your options? You can inject that area, you can treat it conservative with a brace for a while, but if that doesn't heal and is still symptomatic, then surgery is what is needed. At surgery, I'm retracting the superficial MCL, which is seen on the left side of the screen. And then the right side forceps is holding that avulsion piece, which is connected to the deep MCL. So it was really an easy surgery once I opened it. Retract the superficial MCL, look at the deep MCL, and then I just had to fix it in its anatomic location because I could see the bare area where it has come out from. And I just used an anchor and fixed it, and he was back to sports with complete relief of symptoms. There has been a report of this, a large series of 17 patients who had deep MCL avulsion injuries who did not do well with conservative treatment and required surgery. Here is a 17-year-old girl who was seen for a third opinion. So she had a long-standing knee pain, soccer player, no injury that she can recall, and she had a previous scope at an outside hospital for removal of a loose body. At that time, they noticed severe trochlear cartilage loss. Then the patient went to see another surgeon who is well known for cartilage restoration procedures. And when he looked at the patient, looked at the MRI, they referred the patient to Children's Hospital to me to see why did the patient have such big cartilage loss? Is it a rheumatic condition? Do you think it's chondrolysis? So the surgeon called me and said that, can you see this patient, and referred them to rheumatology for any conditions or for idiopathic chondrolysis. So I saw this patient, and you can see that there is significant loss of cartilage on the lateral facet of the trochlea. You can see the medial side on the MRI, the cartilage is intact, but the lateral side is missing. But when I looked at the MRI myself, and I was looking for where is that loose piece, because they had mentioned they had removed a loose piece, but I was still wanted to see. So I looked at the x-ray before her surgery to remove the loose piece and afterwards, and I could still see a big loose piece. It was an osteochondral fracture. So not only was it missed by the surgeon who took out a loose body, because there may be a second loose body in the suprapatellar pouch, but the main reason that the patient had the osteochondral defect on the trochlea is because this is such a large piece in the back of the knee that was missed by the previous surgeon and by the second surgeon who referred the patient for chondrolysis. So I took the patient to the OR, and of course there was a big area that was rubbing against the patella. I took out the piece, but you can see the piece was not, very good quality. It was a big piece. It was partly healed to the synovium in the back of the knee. And once I removed it, I didn't feel that this would heal. So what I did was a lateral facetectomy of the patella to take some pressure off that area. You can see some roughening of the cartilage. The patient may need something down the road. At least at a year and a half, the patient is doing well. But the main important finding here is a missed osteochondral fracture because it was cartilaginous. Even though there was an MRI, it was missed since it was in the posterior gutter. Here is another patient, a 12-year-old male, had injury, had knee swelling, and there are no curveballs here. There is no fracture that I can see and no fractures that were reported. But when you do an MRI, you can see a classic bruise pattern where the posterior aspect of the lateral tibial plateau and the lateral femoral condyle have an ACL bruise pattern. And when you look at the MRI closely, you can see an avulsion of the tibial spine, which is mainly a cartilaginous avulsion because you can't see it on the X-ray, but here you can see that ACL is attached to it and it is displaced. So we went at around 4 months when I got an X-ray because the patient had presented late. These are the initial scans. When I had seen the patient, it was already 4 months. When I got an X-ray, you can see that the cartilaginous piece was ossified, which made my job a bit easier. I just put a screw and fixed it. This is a follow-up, and I removed the screw and everything went on to heal okay, but one can see how it could be missed initially because it was a cartilaginous tibial spine fracture. So one has to have a high degree of suspicion based on examination and then an MRI to confirm it. I've seen several of these. I've seen these kind of injuries. You can see it's a very small sliver of bone. We call it the tibial spine flake fracture. We are looking at it from a multi-center study standpoint right now, trying to collect more cases, and we have at least 20 cases of tibial spine flake fractures like this, which may be difficult to diagnose on an X-ray. And then we also want to see how best to treat them. Another example of a tibial flake fracture, which could be easily missed because it's a very small piece. Here is a 14-year-old boy who was referred after a patellar dislocation for an osteochondral fracture of the patella, so specifically sent for fracture fixation. So when I look at this patient, you can see that this is on the lateral side. And if you have treated patellar dislocation patients enough, or if you know about how they present, most of the avulsion of the MPFL or the MTFL, that is the medial tibiofemoral ligament, is from the medial side, not the lateral side. So this is actually not a common scenario. When you look at the MRI, that the patella is sublux tilted on the lateral side. When we got a contralateral X-ray, you can see a similar finding on the other side. So this was actually a bipartite patella that was misdiagnosed as an osteochondral fracture and referred for fixation. So it's not wrong to fix a bipartite patella if it's symptomatic. That's one treatment, but that was not this patient's issue. This patient had an unstable patella, and the bipartite was not symptomatic. An example of a 14-year-old boy who was running. He hit the wall while he was running, and this is how he presented. His X-ray was read normal, but one has to be suspicious because of the fracture line that you can see on the posterior aspect, especially if you know that these injuries do happen. The reason it's important because there are important structures behind that area, and the fracture may have been displaced at one time and may have auto-reduced or spontaneously reduced. So this is the proximal tibial fracture. An MRI shows the fracture line as well. And the important thing is that the artery is right behind it. So this patient, when he presented to the clinic 3 days later, his calf was significantly swollen. Unfortunately, he did not have a vascular injury, but the concern about compartment syndrome was real. We look at some of the hand injuries. The Seymour fracture is one of them, and this is how the present was described way back in 1966 by Seymour. It's a fracture of the distal phalanx, the physeal fracture of the distal phalanx. It's frequently would present as an open fracture and can have soft tissue entrapment of the matrix and the periosteum in the fracture site. If you look at the anatomy of the nail bed and the distal phalangeal anatomy, then you can see how the extensor tendon would insert on the epiphysis. The flexor tendon inserts onto the metaphysis. So you can imagine if you have a fracture right there, a physeal fracture, how it would open up because of the pull of the flexors. This part would go down, would create space in the dorsum part of the phalanx where the matrix would get then, trapped inside in this area. And once the matrix gets pulled into the fracture site, the nail plate would then come to lie on top of the matrix. So it's not like the nail plate, which is supposed to be tucked underneath here, would come and lie on top of it because the matrix is now in the fracture site. So it would present like this. Yet you have a nail plate here, and then the matrix is underneath in the fracture site in this area here. Even if the fracture is not displaced like this, that is how it would present. And it is an open fracture, high rates of infection if it's not treated right. And this is something at follow-up. So this patient was treated conservatively. Now, is this the correct thing? Do you think that there is anything wrong? One is that you can look at the lunula which is this part here, you can see the lunula it is much longer on this finger compared to the other lunula. So you know that the nail plate is not underneath the nail fold, it's actually sitting on top of the nail fold. So there can be complication of misdiagnosis, infection, and osteomyelitis. You can have growth disturbances like seen here, and you can get nail issues like a hook nail or a nail with multiple fissures in it. The ideal treatment is to remove the nail plate, then remove the interposed tissue from the fracture site, debride it, clean it. Then you can reduce the fracture. Usually the fractures are stable. Once you reduce, you don't need to put any hardware in it. Then you repair the nail bed back together. You can use some chromic sutures, really fine sutures, and you replace the nail plate as a dressing on top of it. And that would also prevent the adhesions between the nail bed and the nail fold. So the nail plate acts as a barrier to prevent adhesions, and then you put them on oral antibiotics. Here is a patient that I seen. So this patient came in the clinic with the sutures done in the ED. Okay, now is this the correct thing to do? And it's not. You can do this. You can see the same thing. It's a femur of the toe. You can see the lunula is much larger here than what it's supposed to be. You can look at the opposite toe to compare it. So I took the patient to the OR and I had to just make an incision here and here, take out the nail plate and take out the interposed tissue and then tuck this underneath. And even though once you take the nail plate out, the nail would then fall off, but you can use the nail plate as a dressing for prevention of adhesions as well as infection. So this is how it looks afterwards. And you can see that the nail plate needs to be underneath the nail fold. And so this is something which we see commonly mistreated outside of our hospital or sometimes even in the ED. Phalangeal neck and condylar fractures are common. This is a condylar fracture. It shows how it remodels, but this is not the best way to treat it. The best way is to fix them because this takes a long amount of time. You can get contractures and deformities, but I'm just showing how a fracture, this is from literature, this is not my case. And it shows how it can remodel. It can present as a double density sign. This is like a supracondylar fracture. When there is a condylar fracture, it may not involve both the condyles. It may just be part of the condyle that is why you may see two densities. And you treat it as a supracondylar fracture. If it's extended, you're going to flex it. Otherwise, that piece that the arrow is pointing would impede, would not allow it to flex the IP joint. So this is how it was fixed. These are further examples or more examples of the fractures, which may look innocuous, but they are not. If they are displaced, it's going to then lead to issues with flexion and a deformity. So they need to be treated properly. The fracture here looks like it's an undisplaced fracture, but when you look at the hand, you can see that the cascade is not maintained. There is a rotational deformity of the fifth digit. It's supposed to point towards the scaphoid or towards where all the other fingers are pointing, and you can see that there is a rotational issue. So that is also important. Just don't look at the x-rays. Look at clinically if there is a deformity that needs to be treated. This is how that was treated by our hand colleagues. Here is a malunion of phalangeal fracture. It's not just a deformity. It also leads to decreased motion and sometimes pain. So it's good not to ignore these fractures and treat them properly and not just say it's a finger. It doesn't matter. It does matter. It is important that you treat it right. The last topic I would cover is the elbow. And we started with this thing about the elbow joint, that why the elbow joint injuries go missed. There's a whole list of injuries where the x-ray seemed harmless and the coin trash was termed by this group of authors in 2010. And this is a list of elbow trash lesions. I'll show you an example of most of these. And you can see how it can go missed and how it should have been treated properly right from the time of injury. One needs to be familiar or at least need to know the different ossification centers, even if you don't remember the order. This is just a mnemonic that, the capitulum, radial head, medial epicondyle, trochlear olecranon, and lateral epicondyle. That's the order of appearance. And there are different years listed, usually a gap of 2 years between each ossification center when it appears. And then there is also another mnemonic for the closure of the ossification centers. When you look at a lateral X-ray, a posterior fat bed sign is always abnormal. Okay, if you see a fat bed sign where the black arrow is, and what that indicates is there is either some bleeding or effusion in the joint, there probably is a fracture or an injury inside the elbow joint. So posterior fat bed sign is always abnormal. A mild anterior fat bed elevation is normal, but not as much as you can see here with the white arrow. This is significant elevation of the anterior fat bed, giving rise to what is called a sail sign. It appears like a sail. So that is also abnormal. And this patient had an MRI from an outside hospital, which shows the fracture that you can't see on the X-ray. Now here is an 8-year-old boy. What is the injury here? Obviously, there is an ulnar fracture. Now, the more important thing is what is happening at the radiocapitular joint. And once you look at the radiocapitular joint, you can see that the radial head is dislocated anteriorly. It's not lining up with the capitulum. So when there is an obvious fracture, it is very easy to focus on the fracture and miss the joint above or the joint below. And that is why when you have a fracture of a long bone, you do need to do imaging of the joint above and the below. So what is this injury? There are no fractures here, but you can see that when you draw a line along the ulna connecting the proximal and the distal aspect, the shaft should be touching the white line. Ulna is a pretty straight bone. So here you can see that there is anterior bowing of the ulna, and that has pushed the radial head out of the capitulum. So this is a Monteggia variant, and this is what gets frequently missed. If you look at the systematic review of missed pediatric Monteggia fractures, where they were missed for more than 4 weeks, there were 30 studies and 600 patients that had missed Monteggia. That's a big number. And it is easy to miss. We looked at our center, and when there was no fracture, the case that I showed you with ulnar bowing and radial head dislocation, there were 8 cases that were missed initially. And if you miss the initial diagnosis, then the treatment does change. You can reduce these fractures acutely, but after a few weeks, you would have to then open it. You may have to do an osteotomy of the ulna, may have to do an open reduction of the radial head. So it does affect your management. So that led to, after this study, what happened at my institution, it led to them putting up a tab of radiocapital alignment. So this is a formal radiology report from our institution. So they fill out every tab on the X-ray. So when you have a radiocapital alignment, that means they're forced to look at it, because otherwise it is easy to miss it. But if you have this tab that you have to fill in, then you're forced to look at it. And that is what the point I'm making is, always look at the radiocapitular joint when you have ulnar bowing or when you have an ulnar fracture, so that we don't miss the Monteggia fracture, which is the radial head dislocation. So isolated radial head dislocation used to be described in the past, but there is no entity like an isolated radial head dislocation. There has to be some ulnar bowing. It is Monteggia fracture unless proved otherwise. Here is a 5-year-old boy. What's the diagnosis? Now, someone may say that what are the centers that are supposed to be there? If you don't know what the centers are there, what centers are supposed to be there, then it's difficult to diagnose what is a fracture, what is a normal ossification. You can always look at the other elbow and compare it, but here this is abnormal. This is the incarcerated medial epicondyle fracture, which also goes missed if you're not suspicious. If you think that this is a normal variant, it is not. And so this patient required surgery. He went to the OR and had that to be fixed. Here is the dislocation in an 8-year-old girl. The dislocation was reduced. What do you see after reduction? You can see that anteriorly there is a ossification center or an osteochondral fracture. This is 1 week later, and you can see that there is a bony ossicle here, but and the radial head appears that it might not be, it lines up with the capitulum, but it may be slightly posterior subluxed. Here is the 1 month later, the patient was stiff. Now you can see that there is some attempt for this to be healing here, and the radial head now is for sure subluxed, not just posteriorly, but on this view also laterally. So this was 1 month later. If you look at the MRI, one can see the fracture, and then you can also see how the radial head is subluxing posteriorly. And that is almost always the case if you miss a radial head fracture. We did a debridement and a capsulotomy on this patient, tried to fix it, but eventually the patient did not heal and had issues, because you can see how rough that radial head is. We were late in approaching this fracture. We tried to fix it, but at 3 months post-op, the patient only had 30 degrees of rotation and significant limitation in bending. And you can see where the radiocapitular line is. The radial head is definitely posteriorly subluxed here. 5 months post-op, now the patient has arthritic changes. You can see here, had significant pain with attempted movement. And we went in and excised the radial head. So radial head excision is done in kids, especially when there is issues with motion pain. And this is a 1.5 years post-op. We didn't have any migration, no significant issues. It's been taken care of by my hand colleague, Dr. Little. This is a clinical picture of the patient. She has restored full pronation supination, as well as flexion extension after the radial head was excised. Here is a report of the intra-articular radial head fracture in a mature patient, progressive radial head subluxation, and rapid radiocapital degeneration. Exactly what happened to the patient in our series. This is a list of 7 cases. You can see all the elbows progress to posterior radiocapitular subluxation and joint degeneration within 4 months. So in 4 months, they all got arthritis. Similar thing happened with our patient, 3 to 4 months and severe arthritis. Here is the outcomes of excision of radial head in patients younger than 18 years. And most of the patients were better. Some patients did have revision surgeries for appositional bone growth. So that is what you need to be aware of. It's better to excise more bone, because some bone may may grow back. But there was no issues at the wrist. That means there was no proximal migration. But you can see that what was the reason that the radial head was excised, and the most common reason was a radial head fracture. Here is a 3-year-old boy who fell. You can see that there is an opacity on the anterior aspect of the distal humerus, and you can see it's a pretty big piece. And actually, it's the coronoid along with areas of the proximal ulna. And so you couldn't ignore it, because this is what gives stability to the joint. You can see the dissection on the medial side, the loops, vessel loops are around the ulnar nerve. You can see the bare area here, which corresponds with this area here. And then we fixed it. And you can see the fixation here, that this is the fractured part that we have placed. And then we put a K-wire to hold it. It seems like it's not holding anything, but it is. And so that patient went on to do okay. Here is another patient. This is my partner, Kevin Little's patient, 4.5-year-old boy. You can see a little bit of opacity on this medial side of the elbow, but it wasn't picked up. Treated outside hospital. He presented to the office 4 months later. In 2 months, he was treated in a cast. He came because he had limited range of motion, mild elbow pain, and significant prominence on the medial side. And this is how he presented. And then these are the other, this is his range of motion. So probably about 30 to 80 degrees range of motion. This was a missed medial condyle fracture. And this you can see on the MRI. It was 180 degrees rotational malunion and subluxation of the joint. This is the ORIF. Difficult to figure out what is where, but the black arrow is the medial condyle piece. Here is the medial condyle piece, supposed to be attached here. And then this is how it was fixed, put back into the position, and these are the K-wires holding it in its proper position. This is a 1-year follow-up on the patient, and the patient did well, but had required more surgery than what he would have required if he would have presented early. Here is a 7-year-old boy with dislocation reduced. What can you see? Obviously, there are fragments anterior to the elbow. This is my patient. The MRI shows that there is subluxation, again, a coronoid fracture. And one can imagine if this is not giving stability, then the joint is going to sublux. But it's mainly a cartilaginous piece. You can see on this section, this is the coronoid fracture that we are dealing with here. And so we, again, open medially ulnar nerve, you can see the vessel loops. And then this fragment was fixed with K-wire. And this is showing the joint, where the joint surface is. This is where the fracture fragment is supposed to be. And so we put it back, the coronoid fragment on top. We put a K-wire. This K-wire goes in and holds it in place. And then we put a suture around this area, like a tension band, and then tied it. This is a K-wire, and then that's the suture that we tied. And then there was an anchor that was placed. So this is how it looks on post-op X-rays. We pulled the K-wire out at around 4 weeks, and the patient did well. This is the final follow-up. The patient did not have any issues with motion, and has done well since then. Here's a 6-year-old with a lateral condyle fracture. What we don't know here is that this need fixation or not. Sometimes a lateral condyle fracture can go missed if they're really undisplaced. Here, the diagnosis is not in question, but how do you know whether there is a hinge that is intact or there is a step off on the articular surface? And that is where the arthrogram comes in useful. It's usually done from a posterior approach using just 1 ml of contrast. You dilute it, insert it, and you can see that the articular hinge is intact here. And this patient did well just with close reduction and pinning. You can put a screw in. That is also another acceptable way of fixation, but we didn't have to open the joint. How do you diagnose a transphyseal fracture, and how do you differentiate a transphyseal fracture from an elbow dislocation when nothing is ossified? So one is that if the radiocapitular relationship is okay, like you can see here, the radiocapitular relationship is okay, but the ulnohumeral relationship is altered, then it's a transphyseal fracture. So compare it to an elbow dislocation where both radiocapitular relationship is altered as well as the ulnohumeral relationship is altered. So if I show you this X-ray, that what is the diagnosis? Is this a dislocation or a transphyseal fracture? And one can say that, oh, I see some bone here, so maybe it's a transphyseal fracture. It could be a fracture dislocation as well. But the reason that we can say that the elbow joint is not dislocated is because of the radiocapitular relationship is intact. You see the capitulum and the radial head are aligned, whereas the ulnohumeral relationship is altered. And then the other reason that we can say that is the direction, that if you have an elbow dislocation, it's almost always posterolateral. And when you have a transphyseal fracture, it's almost always on the medial side. So the direction also gives you an idea. So a final slide is on integration of the AI in detecting pediatric elbow injuries in an emergency department. This was a study recently done in a French university hospital ED. They enrolled 755 children prospectively, of which 352 children had a fracture, a fusion, or a dislocation. They use an AI software. It was called BoneView. No conflict of interest. I don't even know about this software. But the AI assistants improved the clinician's sensitivity to detect an injury by 21%. So it went from 77% to 98%. That's significant. So I think there is a role of AI deep learning going forward. There are a lot of softwares that are coming out, not just for detection, even for measurements, and can help with diagnosis, especially in the ED setting when it's busy with ED physicians. may lack appropriate training to diagnose elbow injuries, and they're relying a lot on the radiology reports, and the radiologist does not have clinical information. So orthopedics is actually best suited to diagnose these fractures, but they don't present to us acutely. That's an issue. But if they present, then you have to be vigilant, you have to be suspicious, and physical examination is the key. There are a lot of ossification variants. It's good that if you have a normal contralateral side, you can get an X-ray that can help to differentiate the variants. You need to be familiar with the commonly missed diagnosis and commonly missed fractures so that it doesn't happen to you. High degrees of suspicion, and then get MRI and CT as needed. CT mainly for intra-articular fractures, whether it's the distal femur, distal tibia, or the wrist, and MRI for osteochondral injuries. And then, if you're not doing too many kids, always phone a friend or call a pediatric colleague who can help you with it. But main thing is that the child should not be at a disadvantage. They should not have a bad result because either we miss something or we misdiagnose something. So thank you for listening to the talk. This is my email. If you have any further questions or any issues, I'll be happy to communicate in future. Thank you.
Thank you, Shital. Shital, you can stop sharing.
Okay.
Thank you, Shital. This was a very enlightening talk. So much of new information. I mean, we think we know a lot, but unfortunately, every time we listen to you, there's a lot of new learning. Thank you so much.
Welcome.
Yeah, a few questions that have propped up, Shital, is so you mentioned in the ankle, in the distal femur, you would like to take CTs when you have a suspicion, you have a low threshold for CTs. And whereas I've seen some of the upper limb ones, they were more of MRs. So do you think there is an advantage with either one? And because why I'm asking is the children, and there is a issue with the ionizing radiation, right, with CT scans.
Right. Yes. Yeah, that's a concern. So now, fortunately, intra-articular injuries of the distal tibia and the distal femur are not common in younger patients. They usually are, either transitional fractures or they happen in the adolescent age range where the epiphysis is ossified well enough that a CT scan would be helpful. So the reason to do a CT scan, you may even see the fracture on an X-ray. So CT scan is not always done to diagnose a fracture, but to plan surgery. So, to measure the displacement, to plan the trajectory of the screws, I have had patients that we think it's a Salter 3 and we get a CT scan, it's a half a fracture. You couldn't see it on the X-ray, but that helps in your surgical planning and not to, and to diagnose all the fracture lines that are there. So that is a reason to do CT scan. The MRI are usually done in younger kids where the center is cartilaginous, where the epiphysis is not ossified yet. Then the CT scan is not going to give you much information because you don't have bone. So in that case, you can either do an ultrasound, you can do an MRI, you can do an arthrogram. There are options, but if you're in the clinic and you're not really sure, and it's a young kid, I'm talking about kids who are prepubertal, like less than 10 years of age with an elbow injury and just a small flake of bone that you can see, then an MRI would be helpful in diagnosing the injury and not a CT scan. So, I would say age-wise and the location-wise, if your epiphysis is ossified and you're looking at an adolescent and you're looking to diagnose or fix an epiphyseal fracture intra-articular, Salter 3 or Salter 4, and again, for the wrist as well, I would get a CT scan for wrist, for the knee, and for the ankle. And if I have a younger patient with an osteochondral injury or even an older patient, but you only see a small flake of bone and you think that there is a big cartilage piece or there is a ligament attached to it, I would then go for an MRI.
And how easy or difficult is to get MR in children, because you need some form of anesthesia, right? And how do you find it in your center?
You need to have a suspicion, a strong suspicion that there is something wrong. So I would not put a kid to sleep unless, I'm pretty sure there is something going on. If you look at the kid, if the elbow is swollen, you don't see any fractures on the elbow. If you examine the kid, there is significant tenderness, bruising. those are, signs suggesting that there is a significant injury. And this typically happens around the elbow joint. I would get an MRI. I mean, as I said, you can get an ultrasound, but the ultrasound is very technique or technician dependent. So, unless you have someone who routinely does ultrasound, it may be difficult to diagnose. So an MRI is then what I would recommend. And yes, if they are less than 7 or 8 years of age, they need to go to sleep for an MRI.
Shital, on a different perspective. See, now there are a lot of papers that have come up to pick up a Perthes, you can do an early MR, right? So there are some studies that say that, okay, get an early MR and you can pick Perthes at a very early stage. And I mean, you're seeing everything. And what do you think about it?
So, traumatic and atraumatic, there are two different, classes. Today we talked about traumatic injuries. But yes, atraumatic, if your suspicion is there, then there are, this diffusion or perfusion-based MRI where you can pick up early on. I don't do a lot of, Perthes. My partner does it, and I've seen that they get MRIs, but I've not seen MRIs unless the patient has symptoms or unless the X-ray is showing something. So I think it probably has a role, and it's evolving the indication. So if you have a patient that is presenting and you're strongly suspicious, then probably getting a perfusion MRI would help. But maybe not a whole lot of centers may have the capacity to do those.
Shital, back to our basics. Now, very often we see a kid with a heel pain, right? They've ran a lot and heel pain, and you have a confusion whether it's an acute stress syndrome or is it a Sever's disease or is it some kind of undisplaced fracture. So are there any tips?
Yeah, so I mean, you have to differentiate overuse from acute injury. So unless they had an injury like a trauma that causes them to, stop running or stop walking, and then you see them and they have significant pain and one episode that caused it, then you treat it as a fracture. But most of the overuse conditions are treated with relative rest. So we don't cast overuse injuries if you have a Sever's disease. Because when you take an X-ray, sometimes the apophysis is fragmented, normally fragmented. And you may confuse that with an acute fracture, but that's or a stress fracture for that reason. Now, there is a little bit of difference, though there is overlap as well. So, if they have significant pain, if the patient presents to me with an overuse Sever's type of thing, I usually would say don't run, don't jump, and, give them the advice and, send them to therapy to learn some stretching, use some anti-inflammatories. But if their pain continues or if they're severe, if they're limping, if they are refusing to bear weight, then probably role of immobilization with a boot or a cast would make sense. So depends on their presentation. But it's easy to differentiate an acute fracture from overuse, but a stress injury and overuse probably have a lot of overlap. If you're inclined to treat it as a stress fracture, then probably there is a role of protecting it with a boot or, with a little bit longer, phase of rest. I can't hear you.
Yeah,
I can't
Shital,
hear
just
you.
one. Yeah, just
Sorry.
one last question. You show that X-ray where the radial head was excised, right? So do you have any tips to reduce migration? For example, muscle interposition or something like that?
No, but we have not seen it. I think that the interosseous membrane would maintain the position. The other thing is when you're excising the radial head, you need to excise a little bit more than not just at the neck, but go more proximal because there is going to be apposition. And so you may come back because that might cause you to have pain. We have not seen migration and it hasn't been reported in kids. It's always a concern, so you check it. And sometimes you would see it, but it's not common, the migration part of it. We have not interposed something in that big space because we want more motion.
Thank you, Shital. Shital, I think that's all the questions that we have for this session. Thank you for this very, very enlightening talk. I'm going to listen to it once again. Thank you so much for joining.
Thanks for the invitation. Thanks for the invitation. And if you have any questions, you can always write to me. And thanks for doing what you're doing. It's important. I have listened to a few of the videos, and they're very